Assalamu alaikum and good morning, everybody. As a continuation of our urology lectures, today we'll be discussing about urological investigations. I'll be presenting this topic, and Dr. Daniel will be moderating the session. So we'll be discussing about urine detail reports, urine cytology, and hematological investigation in urology, like CBC, RFTs, electrolytes, etc. So the urine analysis is the fundamental test that should be performed in every urological patient presenting with urinary symptoms and complaints. And it comes to augment your history and examination once you receive the patient. So there is multiple component of urine analysis test. We'll be discussing it by one in details. Physical and gross examination by grossly examining the sample, and lipstick chemical examination and microscopic analysis, and cultural staining, cytological examination. So there is principles for urine sample to be processed in order to get a proper detailed report. So all urine samples should be processed within 1 hour. And if it is not possible, then should be kept in 5 centigrade in refrigerator. So if it's not processed within 1 hour and kept in room temperature, you will be changes in the sample and its component and would lead to suboptimal detailed report of the urine. So if it's kept for more than an hour, it will lead to increase urine pH or overgrowth of the organism, or it will lead to disintegration of the RBC or WBC scuts, and lead to like suboptimal detailed reports. So in order to get proper report, you have to have some principle to collect the sample, and it's different in male, female, and neonates. In male, the sample that's required is first voided morning sample, midstream urine sample, and clean catch free of any debris. In female, clean midstream urine sample, or in case of recurrent UTI or antibiotic resistant UTI and previous samples, so catheterizable sample will be required. In units, sterile plastic bag with adhesive collar to collect the sample, or can be urethral catheterization or suprapubic aspiration, which is invasive. So there is some like ways how to collect the sample from neonate, like either by using urine bag with adhesive collar, or clean catch, wait for the patient to urinate and get proper like midstream sample, or by stimulating urination by stroking suprapubic area or lower abdomen to stimulate voiding, or by urethral catheterization, or by suprapubic aspiration. So what you see in urine by gross examination, you look for the color. Normally, the color should be pale yellow or colorless in case of patient is overhydrated or the urine is dilute. So various foods, metabolic products, medication, and infection may produce abnormal urine color. So in case you see cloudy, milky urine, you will be suspecting phosphaturia, pyuria, hyluria.
Tell what is value. The rare condition due to the presence of certain acidic effect due to blockage of lymphatics, which rupture urinary.
So red color was either by hematuria, hemoglobinuria, lead poisoning, peace, and rifampicin. Orange color dehydration, or sulfasalazine use. Brown color, ingestion of beans, porphyria, chloroquine, metronidazole, and metoprolol antibiotics. Brown black, methyl dopa, or hemorrhage, or using of sorbitol. Odor, like ammonium smell of urine caused by urea splitting bacteria, for example, Proteus, Pseudomonas, Macrodia, and Klebsiella. And foul insect smell, which can occur in all specimen or bus or inflammation. Throaty smell caused by ketone bodies in the urine, in cases like diabetic ketoacidosis. So we come to the chemical analysis. We mostly use dipstick test. It's a quick and inexpensive test, and results can be shown in 60 to 120 seconds. It's highly sensitive. It's cost effective. It's have like 10 variables you can measure at the same time. And if you individually perform this test, it will take time and uh, costly non-effective. So it's a short plastic stripe with small marker pads that are impregnated with different chemical reagents, which will react with the urine substances and produce color change. So this is the leaflet of urine dipstick. You can see there is multiple variables in the left side of the screen. You can detect for leukocytes, nitrite, the urobilinogen, protein, pH, and blood, and specific gravity, and three other uh, variables. So they will be changed in color according to the concentration of the substance. Like it will be negative, for example, in leukocytes will be negative, and if it's positive, it will tell you also how much concentration is the leukocytes per microliter. Nitrite will be change of color, either positive or negative, and protein also. It will roughly quantify the presence of urine, the presence of protein in urine. pH, like with color-coded variables, will tell you exactly how much is the pH of the urine. So specific gravity normally should be 1.008 to 1.020. And it reflects the patient's status of hydration, abnormal renal function, and renal concentrating ability of urine. So if it's less than 1.008, it's indicate diluted urine and could be due to diuretics, diabetes, insipidus, and renal tubular disease, or increase fluid intake. If it's more than 1.020, so concentrated urine, and it can be caused by glucosuria or syndrome of inappropriate EDH secretion or dehydration. So pH is very important indicator. In general, the urine pH reflects the pH in the serum. Normal pH 4.5 to 8, and average is 5.5 to 6.5. So we can say the urine is acidic if it's 4.5 to 5.5, or alkaline 6.5 to 8. So in metabolic or respiratory acidosis, the urine pH is acidic, and also vice versa for the alkaline. There is exception in renal tubular acidosis, alkaline urine because of the loss of HCO3 and blood is acidic. And in this case, is like the kidney lose its ability to acidify the urine. So there will be alkaline urine being secreted in the bladder. So urea splitting organism most commonly approaches convert ammonia to ammonium ions, which is markedly elevate the urine pH and cause precipitation of calcium, magnesium, and ammonium phosphate crystals, which cause crystallization and Stankhorn stone. Urine pH is acidic inhibition with uric acid, cystine stone, and alkalization of the urine is important therapy for both conditions. So blood or hematuria. Normally, less than 3 RBCs by high power field should be present or even not present. And the degree of color change directly related to the amount of hemoglobin concentration in the urine. Hematuria can be distinguished from myoglobinuria, hemoglobinuria by microscopic examination uh, of centrifuge urine by the presence of RBCs. So in myoglobinuria, there will be no RBCs. There is no cell will be present. And false positive can occur in menstruation and contamination, dehydration, and vigorous exercise. Hematuria with nephrological origin is frequently associated with cast and urine and almost always associated with significant proteinuria. The urological cause of hematuria is unlikely to elevate protein concentration in the urine into 100 to 300 milligram per deciliter or in dipstick plus 2 or plus 3, which is indicate glomerular or tubulointerstitial origin. So there will be also dysmorphic shape of RPCs on microscopy indicate hematuria from glomeruli origin, while urological cause and tubular interstitial are uniformly round shaped normal RBCs.
When there is a globular cause of bacteria, the RBC becomes dysmorphic. The shape changes due to passage from the unhealthy or diseased life. They change their shape and they also get integrated in certain proteins sequence. While in your physical works like tumors or whatever, the RBCs are shape. They're tubular, they're
So anticoagulant at its normal therapeutic dose does not cause any hematuria. Causes of hematuria, pre-renal or renal or post-renal. And pre-renal could be caused by bleeding disorder or overdose of anticoagulants, drugs on renal origin, glomerulonephritis, pyelonephritis, interstitial nephritis, and renal tuberculosis, renal tumor, or neoplasm, polycystic kidney disease, trauma, or impact, or papillary necrosis, or post-renal and ureteric origin, either by stone or neoplasm, or urinary bladder cystitis, stone, tumor, tuberculosis, or schistosomiasis, and prostate, BBH, or carcinoma, urethra, either by tumor or infection, like urethritis. So proteinuria, normal 80 to 150 milligram per day, excreted with urine in 24 hours. Mostly it's 30% are albumin, 30% globulin, and 40% tissue protein. Majority is some hospital proteins. Proteinuria may be the first indication of renovascular or glomerular or tubulointerstitial disease, or it may represent the overflow of abnormal proteins like multiple myeloma. Most cases of proteinuria can be categorized in three categories according to the origin of this proteinuria. So glomerular proteinuria mostly is the most common type and results from increased glomerular capillary permeability to protein, especially to albumin. So 24 urine protein is 1 to 3 grams. And the other one is tubular proteinuria. which excretes low molecular weight protein, for example, immunoglobulin, rather than albumin. And the other type is overflow proteinuria, which occur in the absence of renal disease, and it's caused by increased plasma concentration of abnormal immunoglobulin and low molecular weight proteins, e.g. Bins, Jones proteins, and multiple myeloma. So false negative result in dipstick can occur in alkaline urine or diluted urine, or the primary protein is not albumin. So dipstick only screen for albumin. Protein in dipstick is main albumin. If qualitative tests reveal proteinuria, then should be followed by quantitative test with the 24 hours urine collection. So immunoassay is the method of choice for detecting specific proteins such as dense Jones proteins and multiple myeloma. The evaluation of proteinuria, and it can be categorized on the timing of occurrence, if either is it transit, biotic history, investigate about fever, exercise, or emotional stress, or congestive heart failure, and repeat the urine analysis. If it's normal, there is no further evaluation. If it's abnormal, so consider it as resistant proteinuria and start for evaluating for resistant proteinuria. And resistant proteinuria, you do 24-hour urine protein and qualitative evaluation. So if it's more than 2000 milligram per 24 hours and primarily it's albumin, so you are suspecting glomerular proteinuria. So it is associated with hematuria, with the dysmorphic erythrocytes and erythrocytes cast. So evaluate for glomerular hematuria. So if there is no dysmorphic erythrocytes or cast or no hematuria, then further evaluation should be carried on for specific disease like diabetes, amyloidosis, and nephrosclerosis. So if in 24 hours the protein is 300 to 2000 milligram per 24 hours, then primarily, which is primarily globulin, and it's normal protein, so you are suspecting tubular proteinuria. So further evaluation for specific disease like Fanconi syndrome, drug for heavy materials intoxication, and Balkan nephropathy and sarcoidosis. If the protein is abnormal, so overflow proteinuria is suspected, and evaluate for specific protein abnormalities like Bell's protein and multiple myeloma, hemoglobin and hemoglobinopathies or myoglobinuria. And if the proteinuria is intermittent and related to upright position, so it's designed as orthostatic proteinuria, not related to position, so evaluate as resistant proteinuria, as previously discussed. So glucose and ketones in the urine, almost all glucose filtered in the glomeruli and reabsorbed. But there is certain threshold that it's crossed in serum, then the secretion of glucose uh, will start in from the glomeruli. So the threshold is 180 milligram per deciliter. If serum albumin is more than 180, then you will start seeing glucose in the urine. And ketones normally is not excreted in urine, so presence of ketone in the urine should be investigated. Cause either diabetes or diabetic ketoacidosis or ketoaciduria. Bilirubin and urobilinogen Normally, urine does not contain bilirubin and contain only small amount of urobilinogen. False negative result can occur in the presence of ascorbic acid. Causes jaundice, either hepatic or extrahepatic. Nitrites and leukocytes assays. Anyone is familiar with these two? Nitrite from which cell it's produced or which organism, and leukocytes from where it comes. So leukocytes traces activity indicate the presence of WBCs, which actually produced by the leukocytes, especially neutrophils, and its presence in the urine uh, decrease with the time because of the lysis of the neutrophils. So its presence is indicating of WBCs neutrophils in the urine. Majority of this cause false positive leukocytes is contamination. Presence of nitrites in the urine is strongly suggestive of bacteriuria. So nitrites is bacterial origin, and the previous one is cell origin. So hepatitis is positive for leukocytes, but negative for nitrites. So non-infectious cause is like inflammation should be considered. Sensitivity is 35 to 80%, while specificity is more than 90. It's less accurate if the urine specimen contains less than uh, 10,000 organisms per ml. So microscopic examination, 10 to 15 ml of urine is centrifuged for 5 minutes at 3,000 pounds per minute. The sediment is taken and on the glass slide for microscopic examination and examined under low power magnification, in which you can see erythrocytes, leukocytes, cast, cystine crystals, parasite, or other, uh, or in high power magnification, you can see the shape of RBC and the type of crystals, and then identify the bacteria and yeast. So mainly urinary sediment should be examined for cell, cast, crystals, bacteria, yeast, and parasites. So cast. A cast is a protein coagulum that is formed in the renal tubules and trapped in the uh, tubular luminal continent with the matrix, like some horsetail lipoprotein, which has no clinical significance. RBC. RBC casts contain entrapped erythrocytes and are diagnostic for glomerular bleeding, most likely glomerulonephritis. WBC casts are observed in acute pyelonephritis or glomerulonephritis. Fatty casts are seen in nephrotic lipiduria or hypothyroidism. So identification of crystal in the urine is very important for stone disease, which help determine the etiology. Identification of cystine crystal establish the diagnosis of cystinuria. Crystal precipitate in acidic urine, calcium oxalate, or uric acid or cystine. Or some crystal which is precipitate in alkaline urine, calcium phosphate or triple phosphate crystals. So this is the shape of calcium oxalate crystal in the urine.
The shape of crystals are very important to identify the type of the screw. It is like it's a picture. The crystals are hexagonal shape. So this is typical for 16 crystals. While in previous slide they were tidal shape, which is typical of calcium chelate disease. And that's the these are the triple phosphate replacement which usually occur in which are present in agon which are typical of coffin lid shape. See the image.
So bacteria. Normal urine shouldn't contain any bacteria. In a fresh and contaminated specimen, the finding of bacteria is indicative of UTI because each high power field between 1 to 20,000 and 1 to 50,000 bacteria per ml. So each bacterium seen per high power field signify a bacterial count of more than 30,000 per ml. And therefore, 5 bacteria per high power field reflect colony count of about 1,000, uh, 100,000 per ml. Yeast, the most common is cell found in the urine is Candida albicans, which is biconcave oval shape of the yeast can be confused with erythrocytes and calcium oxalate crystals. So can be distinguished by characteristic budding and height. So urine cytology. Urine cytology is requested when urothelial malignancy is suspected. Not used for routine tests or screening. However, it's useful in radiological suspected lesions, especially in high-grade malignancies. It's highly specific for high-grade UCC, but sensitivity decrease for the low-grade urothelial carcinoma.
So why it is that there high sensitivity urine cytology and high grade with malignancy and low sensitivity? Why is it? In high grade malignancies, the tumor cells usually loses their adhesive capability, so they get disintegrated from the tumors and get get floating in the urine, which results in process. When in low grade malignancies, the adhesive capabilities of the tumor cells remains. That's why they get degraded to the tumor and does not get discharged from the.
So this is a cytological slide in urothelial carcinoma in figure A. It's normal cells, and in figure B, it's the abnormal or malignant urothelial cell. And the next slide, we see the characteristics of these cells. There is a squamous cancer in the urine. The cells is the malignant cells are large with pale blue cytoplasm. You can identify it, and dark nucleus, which is hyperchromic. Uh, Blood investigation for evaluating the urological patient. There is some set of investigation, urological and hematological investigation. You order CBC with differential. You will see for HP, and you will go for TLC with differential for to detect any underlying infectious process or sepsis, and urea creatinine and electrolytes imbalance, and BT, in case of hematuria or pre-op evaluation of the patient, and serum calcium or BTH level for stone workup, and uric acid level in case of uricosuriya or uric acid stone, or oxalate or cysteine level as part of stone workup, or metabolic study of urine, or genetic study for hyperexaluria. So BSA. BSA is glycoprotein in the caliciprine family produced by prosthetic lumen epithelial cells. Serum BSA measure the BSA and the circulation. So it's of two component total PSA, which equal to 3 PSA plus complex PSA. Complex PSA is bound to other proteins, mostly anti-alpha 1 chymotrypsin. PSA half-life is 2.2 to 3.2 days, which is androgen-dependent protection stimulated by androgen. PSA is not capable of diagnosing prostate cancer, only estimate the risk of prostate cancer.
Can anyone tell me what is the function of PSA? Does what is the function of PSA? Is normal or not? Okay, Gerard. If PSA is normally present in the semen. It helps in liquefaction of the semen. It is normal. But if the level of PSA increase in blood, it is it is indicated certain which Dr. Martin mentions.
So there is condition that can alter the level of PSA, either increasing or decreasing. So the condition that elevate PSA, prostatic cancer, BPH, and NBPH is the PSA is proportional to the size of the adenoma or the gland. Uh, Infections like prostatitis, prostate manipulation like DRA or periurethral catheterization or trauma or cystoscopies, ejaculation within few days. As Dr. Daniel discussed, one of the main function of PSA is liquefying of the semen. So it get stimulated and its projection is increased if ejaculation happened within the last few days. So PSA increased with the age, and some condition that reduce the PSA, 5-alpha reductase reduce the total PSA by 50% within 6 to 12 months, but does not alter the PSA. So low serum testosterone and prosthetic surgery. Prosthetic surgery, there will be a plateau or certain increase of PSA immediate post-op that will follow by the regression of PSA because of the manipulation or increase. And prosthetic radiation, the same like prosthetic surgery. And hemodialysis to alter the free PSA, but not the total PSA. So PBSA shouldn't be used in dialysis-dependent patients. So the component of this cancer is not epithelial cell, some other origin. So it will not be like in organ. So topic is just introduction to the investigation. That one will be discussed in details in the topic of prostate cancer.
Not more than 50%. But if the patient comes with PSO more than 15 nanogram per deciliter or more than 40, then it's due to urinary cancer. It is and we have to rule out the cancer by biopsy for the investigation. The ejaculation and prostate manipulation does not increase significantly.
So VMA catecholamines testing uh, dopamine, norepinephrine, and epinephrine are produced by chromocytoma in varying amount. Release of these compounds in the bloodstream is often paroxysmal. So methanephrin testing is together normetanephrine and methanephrin are known as methanephrines because of the conversion of catecholamines to methanephrin is an interrupted process with chromocytoma. Measurement of the plasma concentration of methanephrin is much more sensitive in the means of tumor detection. So than the measurement of rising in the plasma catecholamines, which is maybe paroxysmal. So DMA is the primary end of metabolites of catecholamines. So synthesis of DMA requires deamination of the catecholamines on their metabolites by monoamine oxidase enzyme and occur not only in the adrenal medulla but also in sympathetic nervous system. Therefore, the relative raise in VMA level in the presence of pheochromocytoma is much less dramatic than the raise seen in the level of metanephrines. And the sensitivity of VMA is low, below 65, but the specificity is almost 99%. So tumor markers that can be used as a part of urological investigation, AFP, indicator of yolk sac tumor of testes, beta HCG, choriocarcinoma, and prolactin, testosterone, FSH, and LH, hypogonadism. This is just an introduction to the this investigation. Every investigation of this will be discussed in details, and its clinical application will be discussed separately with every topic. So that was it for today. If there is any question, sir, I'm not exactly familiar how much it's raised, but it's there is significant raise with the age. So basically, using BSA, it's like the actual BSA level in density and velocity and like BSA, like so there will be great raise like in the total BSA in general because of the presence of the secreting cells, which is the origin of the uh, prostatic cancer. So because of the this plastic cells has unproportionate growth and like behave like there is no control over its protection and growth. So and the overproduction of PSA will exceed the limit of like bounding this PSA to other proteins like this the normal presence of this alpha glycoside. Thank you.